I think we'll start with we'll introduce the ECHO team. Renee, would you mind introducing yourself to the group?
My name is Renee Bolio-Banks, Indigenous Cause. I'm from Leech Lake. I am the Eagle Clan. I've been at NACC for about 5 years. I'm the one of the elders and residents and spiritual care providers. It's nice to meet you all.
Miigwech. And Nikki?
My name is Nikki Jardina. I am a nurse at NACC. I've been at NACC since about 2017, and I work with the ECHO team and do harm reduction work and infectious disease care coordination.
And I'm Lindsay King-Cooney. I'm the harm reduction coordinator and also coordinate the Midwest Tribal ECHO. We also, Dr. Robbie is our medical officer and family practice physician, and she couldn't be here today, but she also leads the team. So we'll do some announcements. I'm going to share my screen. All right, so welcome to Midwest Tribal ECHO. We're the Opioid Use Disorder Education and Treatment Series. Today, we welcome Clare Schmidt and Yarelix Estrada from Remedy Alliance. They're going to talk to us about drug checking. A little bit about NACC. So we're the Native American Community Clinic. We're an FQHC. We were established in 2003, so we've been here for 20 years. This is just a list of all the services that we provide. We have several job openings here at NACC. There's our website at the bottom. So if you're interested or if you know anyone that would be interested, feel free to visit our website and you can read more about these job openings. Some session guidelines, please, no protected health information. If you could mute yourself if you're not speaking. If you're willing to turn on your camera, we'd love to see your faces. And then if you could let us know who you are in the chat, so your name, title, organization, and email, I can get information out to you. You probably know this by now, but we switched to a new format the first of the year. So we're going through iEcho now to get the Zoom link. And then also all the recordings and slides are on that for you as well. Some announcements. So next ECHO is coming up. We have on March 6th, Kyle Lipinski and Gina Lancy, and they're going to be talking to us about solidarity and recovery within unsheltered communities. And then on March 20th, we have human trafficking and SUD as risk factors from Anna Negrete and Pamela Hughes. This is just a list of other ECHOs that cover similar topics on opioid use disorder. So let me know if you want more information on that. We do offer CME credit for those who are eligible. We just ask that you fill out the post-evaluation survey, which I'll put in the chat today, and then also send that out to you in an email. And then finally, case presentations, we welcome if you have anything to share. They make for great discussion, so feel free to put something in the chat or email me if you have something to share. And I think that's it for me, so I'm going to stop sharing. And I'll hand it over to Claire and Yarelix. Thank you.
Thank you so much for having us to speak today and for the introduction. We also have Taylor Wood from the Chicago Recovery Alliance, who is going to be presenting with us today. And maybe I'll have both Yarelix and Taylor introduce themselves as well. But my name is Clare Schmidt. I'm the drug checking technical lead with Remedy Alliance. And I'm actually also based in Minneapolis. So it's really special and very cool for me to be here presenting with you all today. Yarelix and then Taylor, and then I'll start the presentation.
Hi, everyone. Thanks so much for having us. It's really great to be able to connect with you and present. I am based out of New York City in the Napping-Canarsie territories, and I work at the New York City Department of Health doing the drug checking program there. But I also work with Remedy Alliance with Claire and with Taylor doing drug checking trainings. So I'm happy to be here, and I'll let Taylor introduce themselves.
Very happy to be here as well. It's an honor. Taylor Wood. I am, in addition to Remedy, also working with Chicago Recovery Alliance, coming out of Chicago. But really happy to be here with you all today. Thank you.
Okay, and I will start sharing my screen. Can everybody see that? Okay, lovely. I'm doing some emergency childcare for my sister, so I have this little one here with me today. So if she is babbling and gurgling, it's because she's also very excited about this. So okay, so I'm gonna kind of start off with just an introduction of community-based drug checking, what it is, what it looks like, why it's important. And then Yarelix is going to go a little bit more in depth about what that actually looks like in practice on the ground in New York City, and some of the challenges and successes that they have had. So among people who use drugs, there has always been a long-standing practice of drug checking. People have relied on their senses, on how something looks, on how it tastes, on how it smells, anything kind of unique or special or different about that particular substance, in order to reduce their risk and also to communicate that among other people in their own community. So we've seen this with like bad batch boards at harm reduction programs, where if there's a particular stamp or a particular logo on something, people will try to communicate and disseminate that knowledge to their community. Traditionally, the type of equipment and the type of technologies that we're using in community-based drug checking are things that have been traditionally used for prosecution, for criminalization. There's things that like the police or DEA have had access to, or even maybe like academic research teams have had access to, but we haven't up until, I think we started drug checking in the US in 2019. And up until then, we really hadn't had access to that level of technology or that level of knowledge in our communities. And the organizations that did, again, law enforcement, DEA, and academic institutions did not always transmit that information back to the community that was most impacted by the drug supply. Drug checking in the US started with a lot of the festival and nightlife scene, so reagent testing with DanceSafe, and testing drugs in that setting. Community-based drug checking and what we're talking about today is slightly different. We use different technology. We use infrared spectroscopy and test strips, and we're working out of harm reduction programs typically. So what is drug checking? At a very basic, at a very literal level, drug checking is a harm reduction intervention that gives people who use drugs more information about whatever they are consuming and helps to minimize the harm that can result from taking an unintended substance. And I'll also add, reduce the harm that can result from taking maybe an intended or an expected substance in an unexpected amount. So that's the very literal definition of drug checking. I also like to think about drug checking in kind of theoretical framework, maybe. And I think of it as kind of at least three steps or three pillars, and each one kind of expands the scope. So again, that first level is that individual one-on-one risk reduction. So again, it's somebody having a direct conversation about a particular drug sample with a technician, and they are receiving information about that particular sample in order to reduce their risk, in order to know what is in the sample that they're actually using. The second level about drug check, or the second kind of tier of drug checking, is this idea of engagement and outreach. So we know that there's a very wide spectrum of people who are using drugs. Some people, their preferred route of administration is injecting, but for a lot of people, folks are smoking, folks are taking pills or ingesting in different ways. And sometimes traditional harm reduction programs don't have tools, or they don't have ways to engage with these other communities and other populations of people who use drugs. So when I started doing drug checking in Boston, at that time, we didn't have any safer smoking equipment. We were only providing syringes. And so the population of people that were coming to access our services were, of course, people who were predominantly injecting. When we started doing drug checking, we started having, people who had never heard of our program before, people who had never engaged with our program or had never sought harm reduction services, finding us. We were not in an easy place to find, but they found us and they came in and they're like, hey, we heard that you can, check my pills that I'm using. Is that something you all do here? And so we were able to, offer something to other communities of people who use drugs and really kind of leverage that engagement and outreach tool. And then the last kind of level is really about liberation and power, making sure that people who use drugs have the consent and bodily autonomy to know whatever is in the drugs that they are using. It can, supply kind of like a feedback loop into the drug supply. There isn't, I've said this before, but like there isn't like an Amazon review, for the drug supply. People traditionally like haven't had that information, haven't had that knowledge. And so it can kind of help create a feedback loop into the drug supply. And then I always like posing this question, right? The drug supply is highly unpredictable. It's very erratic. And, as we're building up all this infrastructure around drug checking, the goal of which is to make the drug supply more predictable, less erratic, more consistent, is the goal of drug checking really to make itself obsolete in favor of knowing what is in the drug supply. So we, that stops being the variable and we can focus on reducing the harms that people come into contact with from, excuse you, June, in other ways. I'm gonna not spend too much time on this, but there are different kind of arenas of drug checking. Right at that top level, we have surveillance and monitoring. So surveillance, the difference between surveillance and monitoring, surveillance is typically leads to criminalization and prosecution, whereas monitoring is intended to be for public health response. And the biggest difference really is with monitoring, the information intentionally gets circulated to the community in a way that is easy for them to understand and is translated in a way that is actionable information for them. Kind of on the second level, we have our broad overarching surveillance versus monitoring. Kind of that next level down is the local drug landscape. So drug checking programs are able to kind of know and identify what is in their local supply. And that allows harm reduction providers to give specific harm reduction interventions and harm reduction advice based on what is in their actual drug supply. And then again, that individual level drug checking is that kind of individual one-on-one conversation, individual intervention about a person's particular drug sample that they brought in to have tested. So I've talked about this a little bit, but what have there's about 30 drug checking programs that are up and running in the United States right now. What have we learned so far? Oh, it's okay, baby. First is that the drug supply is highly predictable and erratic, both in the different contents that are found in drugs and in the amounts of different components. So it's not uncommon to, test 4 different opioid samples and have wildly varying amounts of fentanyl between those 4 samples. The drug supply is also highly regionally specific, right? So what the drug supply looks like in Chicago may look very different from what it looks like in Minneapolis, may look very different from what it looks like in northern Minnesota and Duluth. We also know that different classifications of drugs have different supply characteristics, right? So we know that particular cuts and particular adulterants are more likely to be found in cocaine versus fentanyl. We know what kind of adulterants or bulking agents are used in opioids, and those are really specific to opioids versus stimulants versus ketamine or MDMA or something like that. And we also have learned a lot about how the risk of drug use lies in this unpredictability and erraticness. And it's really this unstableness and inconsistency that continues to cause the harm. I like to, I use a lot of analogies. I also bake a lot. And I like to describe drug checking kind of using this baking a cake analogy. So what we're doing when we're doing drug checking, really it's analytical chemistry, but it's being applied in a direct service setting. And so drug checking is like if I hand you a cake and I say, okay, tell me what this original recipe was, right? That's really what we're doing with drug checking. We're taking this final product and we're working backwards to try to figure out what those initial ingredients were. It may be pretty easy to identify the major components like flour or sugar or maybe eggs versus oil. But the smaller things, the thing that makes the cake actually work, like baking soda or baking powder or vanilla or spices, that might be a little bit harder to identify. And it's going to be a lot harder to determine the amount of those smaller things. And the amount makes a really big difference, right? If you double the amount of baking soda, it's maybe only 3% of the actual volume of the cake, but doubling that is going to drastically change the outcome of the cake that you have. Similarly, the more that you know how to bake a cake, the easier it is for you to piece together that original recipe. And we can kind of extend this analogy to the drug supply and the drug landscape. The more that a technician knows about drugs, about how drugs work, about what the drug landscape looks like, the easier it's going to be for them to kind of piece together that original recipe. I'm going to briefly talk about the different technology that's used. So from left to right, we're increasing in the cost, the amount of time and the complexity of these different kind of technologies that are used. And I also want to say that every drug checking technology that exists has limitations, right? And so we layer different technologies on top of each other to try to compensate for some of these limitations and shortcomings. So on the left, we have test strips. Those are immunoassay test strips. They're a purely yes/no answer about whether or not something is in the sample that you're testing. Reagent testing, again, we don't really use that all that much in point of care drug checking. But we do, that's predominantly used in festival settings. And then FTIR, it's a Fourier transform infrared spectrometer. That is the equipment that is predominantly used in point of care drug checking settings. And then drug checking programs will partner with confirmatory or secondary verification labs that are using equipment like a liquid chromatography, liquid chromatography mass spectrometer or gas chromatography mass spectrometer to provide further in-depth analysis on a drug sample. Yarelix, can I have you talk through this? And I'm gonna put the baby in a different place. I'm so sorry.
Oh, no worries. If you want, you can stop sharing screen and I can go through it. Because kind of coming where you
Sure.
off
Yeah.
on.
Thank you.
Yeah, of course. Thanks for presenting.
Yes.
All right, I'm going to share my screen and kind of pick off where Claire left off. Okay, so I'm just going to go into a little bit more detail of what Claire already mentioned, which is also specific to where a lot of drug checking programs currently stand in the US, like the technologies that we're using and how they work and what their limitations are. So as Claire mentioned, we use the Fourier transform infrared spectrometer. It's a mouthful, we say FTIR for short. And the benefits of this machine, which is a lot of the machines that folks that are doing drug checking right now are using, is that it can provide real-time analysis of the samples that are analyzed. So if somebody brings something in, they can get the results, within 5 to 10 minutes of bringing it in. So it's real-time analysis. Someone doesn't have to wait, 3 weeks to a month or longer to get the results back. It can give us the information on active ingredients, on things that are potential contaminants, and also fillers, so usually inactive things that are found in substances. And the primary limitation, which I'll talk about in a little bit, is that it has a 5% detection limit. So for example, if there's somebody that brings in a sample of heroin and that heroin has 3% fentanyl, the machine may not pick that up. And because of that detection limit, it's just a limitation that the machine has. And for that reason, we also use immunoassay test strips, so the test strips on the right, which I think a lot of folks are probably familiar with and maybe have used already. And the test strips that we primarily use are fentanyl test strips, xylazine test strips, and benzodiazepine test strips. Some programs may also use LSD test strips if folks are bringing those sorts of samples in. And the reason why we use those is because they are able to see something if there's something present below the detection limit, and it has high sensitivity, meaning it's able to pick up even tiny amounts of substances that might be found in a sample. The limitation here is that it provides a binary result, so it either says yes, it's there, or no, it's not there, which is obviously not very specific in terms of like what kind of fentanyl or what kind of benzo might be in there. But it does let us know that there's something in there. And the other limitation is that there's a lot of potential user error issues that can come with test strips. Sometimes there's variability within lots of the test strips, but they are still a helpful tool that we use alongside of the machine. So I won't go too deeply into this, but one of the other nice benefits of the machine that we use is that it uses infrared light to be able to run the test, meaning that the samples that are brought in are not destroyed. I know some people are kind of hesitant about thinking if people will want to bring in their substances to be tested, because people might not want to, like, hand their drugs over to someone. But these machines are nice because they just use light. So whatever they give us, we are able to give them back, except for the small amount that we keep to use for the test strips. And we're able to test this using different libraries, and it requires minimal sample preparation. So the person really only has to crush up, or we only have to crush up whatever samples they bring in. And we can only test powders and pills. And in some cases, we can test liquids like GHB or GBL. So the machine, this is something that if Claire pops back in, she can show the budget. But the machine costs around $40,000 in total, including the libraries and things. So what the FTIR can and can't do, it can use a library, a massive library, to identify different substances. It can identify the different components in a sample, and it can provide a rough idea of quantification. And this rough idea is because of that 5% detection limit, and because we're also using this machine to do something that we kind of, as people who mostly aren't chemists and are, just people from the community working in public health, we're not able to know exactly what percentage of different things are in sample. So we're kind of approximating what's in there. And I'll talk a little bit about this later with how we're using that to do fentanyl approximations in New York City. But what the FTIR can't do is it can't detect things that are present under 5%, like I mentioned. It can't provide actual quantification because, for example, if there's a sample that has 2% this and 3% that and 2% this and a bunch of that, we're missing all of those things. So the estimations that we're providing will never be perfect. It also cannot reliably detect the full range of fentanyl analogs. There's different types of fentanyl, so we can't always detect that. And sometimes when we test the samples, if we test a very, very small amount on the machine, we can't necessarily say that that is representative of a much larger sample. So that's also the caveat of the information that the FTIR can provide. And I won't go too deeply into this either, but this is what Claire mentioned as well with secondary testing. So because of the limitations of the machine, it's super important to be able to work with a lab so that we can do training, and also so that we can know what even is in our supply. So when we're first doing drug checking, there's a lot of things that are potentially part of the supply, but the only way that we can verify for sure that something is in our supply is by sending off to the lab for testing, just to get an initial idea of what's in our drug landscape. Like some places have no heroin at all. We in New York City have a good amount of heroin. It's usually mixed with other things like fentanyl and xylazine. But the only way to really get a sense of what's in there, especially things that might be present under that 5% detection limit, is working with that lab. All right, so I'm just going to go over the process that we have, and then I'll pass it back to Claire to keep talking about some of the procedural things and the budget. So the way that we do the process is we have somebody come in and they put the drug on the machine. So the crystal that I showed earlier, here is the crystal. And then we wait for the machine to analyze the contents. Then while that's happening, we also test with test strips. For samples that we want to get a better idea of what's in the sample beyond what we might be seeing with the FTIR, we also send it to the lab for secondary testing. And then we provide harm reduction counseling with a participant, which if there's a little bit of time, we'll talk a little bit more about what the harm reduction counseling piece is, because I think that's a really important part of helping people understand what's in their drugs, helping them understand how that intersects with their health, and also helping them figure out what their next steps might be with what they want to do with these results. And this is what it looks like. I'll kind of come back to this when we trade off, but I'm gonna hand it back off to Claire for her to go back into where she was going.
Thank you, and apologies to everybody. Thank you so much for your flexibility. We will start back up here. So I think Yarelix covered this a little bit, but this is kind of what that process looks like. There's of course different models, but I think this is kind of the one that's the most common and kind of like the base, kind of basic entry model, and then people can kind of expand from there. So with community-based drug checking, the person will access a service at their local harm reduction program. They will then meet with a technician to do a really short intake form. We collect a little bit of data around, what they expected the substance to be, if they've used it or not, and if they have used it, kind of what their experience with that particular sample was. Once the technician kind of does that initial intake, they will then they'll start the actual analysis process. So they'll work with the FTIR, partnered with the test strips. They will then take the information and the data that comes out of the FTIR, integrate that with the information from the test strips, and then deliver that harm reduction counseling to the service user. Depending on the context, on how complicated the sample is, if there's any unanswered questions, that sample will also be sent to the secondary verification lab to do kind of a full workup of the sample. And then that information is again provided back to the technician to then be kind of transmitted to the service user, or it may be provided directly to the service user online. I'm going to skip over that. So for programs that are interested in doing drug checking, there's a couple of things that should be in place before kind of things get rolling. Drug checking is a pretty complicated, or it's not complicated, but it's a pretty intensive intervention. It's pretty resource intensive. And then the training process is also can be quite, the training process takes a long time, and there's a lot of knowledge that goes into being a technician. And so it's important to kind of have everything set up for success so that when your technician does start training, they can kind of hit the ground running. So for programs, in order for them to kind of start that training process, they need to actually have the instrument, have the machine that they're going to be using. They should have the technician who is going to be doing the providing the actual drug checking services identified. They should be able to get local drug samples to test and to use during the training. They need to have a plan for secondary verification or confirmatory testing. And programs should also have a plan for how and if they're going to engage with law enforcement. There's no right or wrong answer to this question, but it's an important conversation for programs to have. Here is kind of a sample budget. So again, the biggest expenses are going to be the equipment itself. So the FTIR, there's different brands and different companies, but the one that most folks are using comes in around $46,000. That is a one-time purchase. So a lot of these costs in the budget are going to be front-loaded during your first year. Same with the training that comes in the first year. And then a lot of the secondary verification testing will also be front loaded that first year, as that's used to kind of verify a technician's training. So the first year you might have more, you might end up sending more samples for confirmatory testing than you maybe would afterwards. This is kind of like what the sample timeline for implementation can look like. So the pre-implementation phase can last, anywhere from 2 months to a year. It really depends on, the environment that the program is operating in, what their appetite for risk taking is. A lot of the things that end up taking a long time are questions around legality, and sometimes, especially with government organizations, things just take a long time to happen. During this pre-implementation phase, programs should also be engaging with the community. They should be kind of talking to people who may be using the service and asking them like, hey, how do you want this to look? This is, this program is for you. What information matters? How do you want to receive that information? Where do you feel comfortable accessing this service? What are concerns that you have? How can we reduce those concerns? Really doing a lot of engagement work with the community. Purchasing the equipment can take some time. It's anywhere, I'm not sure what it is right now, but typically it's anywhere from 5 to 6 weeks after you place an order is when the machine actually shows up. You also need to prepare the other types of equipment that you'll use. So test strips, alcohol wipes to clean the instrument, things like that. The initial training phase is anywhere from like 3 to 6 months, depends on the volume of samples that you're getting. But the way that we do it at Remedy is we do a 3-day hands-on in-person training with local drug samples. And then we send programs back to their respective sites where they do kind of like a practice phase. So they're analyzing drug samples, they're analyzing scans, and also sending in all of the samples that they get to confirmatory testing, so they can compare their results on the FTIR to what the lab found. And during this time, they're also meeting remotely with a trainer to do a lot of one-on-one TA and troubleshooting and kind of really solidify that knowledge. And then ongoing capacity and education. So again, the idea I think is we've seen a lot of success with kind of this like apprentice model. So once you have a solid knowledge base in your organization, really bringing in other people to kind of expand that programmatic knowledge and make sure that if a technician decides to leave, that programmatic knowledge doesn't leave with them. I am going to, I think, skip kind of the drug checking models, but just know that there are different types of drug checking models that are out there. This is kind of a map of where current drug checking programs are. There's about 30, I think, drug checking programs that are up and running in the US right now, and maybe another like 11 or so that are kind of in that implementation process. So they have a budget, they're working on purchasing an instrument, they're working on hiring a technician, and are planning to start operating in the next year or so. And then I have a couple different kind of snapshots of what different drug checking programs can look like. So this is an example of like a really low threshold drug checking program. So this is one that does not have a point of care component to it. So they're not immediately receiving results. This is more like the sites are collecting samples from service users and then are sending the samples to a lab at University of North Carolina. And then those results are uploaded and communicated to the harm reduction staff, who are then providing results back to the person who gave the original sample. This is a really easy, low threshold way for programs to kind of start laying the groundwork for drug checking. It helps, you can get a bit of an idea of what's in your local supply. You kind of get like a small example of what the benefits might be, and then you can kind of take those lessons that you've learned and then turn those into the point of care program down the line. I think a lot of the programs that exist right now are in predominantly pretty big cities, so like Chicago or New York. There are programs that are in more rural, kind of more rural parts of the country and also more conservative parts on the country. And there's, I think different considerations, again, depending on what your context is. So, some programs, Yarelix will talk about this a little bit, but some programs take more information maybe than others. Whereas if you're in a more conservative environment, in this case, the service is completely anonymous. They're not collecting any participant information at all. In San Francisco, they have a mobile drug checking program. So they do drug checking out of their mobile van. So they're able to kind of travel to areas of need. They're able to respond, to requests from the community, or if there's a particular neighborhood or an encampment that is needing some drug checking services, they can respond to that. And Taylor can talk about this as well, but in Chicago, they do like a Dropbox system. So folks can drop off samples if they don't want to wait for the results or if the program is closed. So they fill out a brief form, leave their contact information, provide the sample, and then the technician will later collect samples from the Dropbox to test and then get a hold of the participant afterwards to deliver their results. And then in Boston, they're doing kind of like a hybrid mobile a hybrid model where they're providing drug checking out of their brick and mortar SSP site, and then also doing mobile drug checking while they're on outreach. And the mobile drug checking is specifically targeted towards community of color because we realized during the first year of operation that, most of our participants were people who were white, and there are significant barriers that people of color experience accessing drug checking services, right? There's a higher risk of criminalization, higher risk of prosecution. And so we did some surveys in the community, and the answer that came out of it was like, we really have to actually take the service specifically to those communities. So that is what things are looking like in Boston right now. And then I'll close with this. So I think one of the beautiful things that we've seen with drug checking is that it really allows communities to be really creative and kind of, identify their own ways in which drug checking has really been helpful. So these are some questions that have come from the communities themselves that were able to be answered through drug checking. So I will stop there. Thank you again very much for your flexibility, and thank you, Yarelix. And then I think she's going to talk a little bit about what things actually look like on the ground in New York City.
Yes, I think we're getting short on time, so I think I'd like to open things up to see if folks have any questions or, if there's specific questions that come up, we can just answer them directly and from our experiences amongst the three of us. So yeah, just want to open things up if anybody has any questions or things that they're interested in based off of drug checking that we presented so far. Yeah, I see Jeff, you have a question.
Yes, and thank y'all for all the work y'all done, and this is, fantastic information. We're down in rural South Carolina. Our clientele is a little different than it is in the bigger cities such as Boston, New York, and so on. And we've kind of fought this issue because nobody has anything y'all have with the $40,000 machinery and stuff like that. The only people that have access to that here is the law enforcement agencies, and primarily SLED, which is our state law enforcement agency. They have a fantastic lab. I'm sure they have stuff like that, but they're so backlogged, they're not going to check drugs for people to consume. And this is where we're kind of fighting an uphill battle. We're not sure. I know my take on it. I'm retired law enforcement. I get it. I know people are going to, do what they want to do. And Claire, you mentioned Dance Safe earlier, and we ordered some stuff from Dance Safe. and I put together packets with a test strip, the scooper, cap, the instruction manual for field testing, out there. And I think that's more for the, the individual user to find out whether or not their stuff has fentanyl on it. And in a meeting yesterday, actually, with the state agency, we asked about that, and I said, the downside I see to that is somebody's going to say, hey, my stuff had fentanyl in it, and I didn't want that, and they might go back to the dealer and seek some sort of retribution. And I was actually surprised by the response I got, where the state agency was telling me everybody that they had talked to that had done that, they were testing to make sure there was fentanyl in it because they wanted that more aggressive high. What are y'all seeing when it comes to test strips and their usage and their what they're capable of, what they're not capable of? I know the machine won't detect less than 5% with these particular kits. How much fentanyl does it take for them to recognize it?
Yeah, so I can speak on this a bit, and then if Claire or Taylor want to jump in, they can. So the test strips they're really, really sensitive. They're really great at picking up even like minuscule, tiny amounts of fentanyl. I'll say in our drug supply in New York City, we've seen something around 97.5% of things sold as opioids, like dope, heroin, etc., test positive for fentanyl. Like it has fentanyl in it.
Mhm.
So at this point in our supply, we basically assume that everything has fentanyl in it, and then we do have these kind of, maybe in the last 2 years we've seen maybe 10 bags of heroin that don't have fentanyl in them.
Okay.
So for us, the test strips have been a lot more useful for people who are opiate naive. So people who are only using cocaine, only using methamphetamine, only using ketamine, not using opioids, because they're people who are not seeking fentanyl at all. And that's we've seen that it's been preferred. Although, yeah, there are definitely some folks that are also using the test strips to like identify that there is fentanyl in their drugs. I will say that the test strips they're quite useful, but they do have their limitations in that you need to have particular dilutions for them to work properly. Otherwise, they can cause false positives. So, for
Right.
example, with like meth, ecstasy, MDMA, if people put too much of the drug and too little water, it can cause a false positive, and it can make people think that they're having fentanyl in their drugs when in reality they're not. And so that's just something that we have to kind of be careful about when we're training people on how to use them. And the other problem is that there's sometimes variability within the lots. Like the manufacturers sometimes are not the best at being consistent. So there are sometimes mistakes that come from the manufacturers themselves. And that's something that unfortunately we just kind of have to live with, that they're an imperfect technology, but they are still pretty helpful. And I think when we give out kits to folks, we try to put several strips in there just in case if there is something that's wrong with them. Then somebody has the ability to test again with a different one to see what's going on. And I'll also finish with saying that, like, in New York City, we've been working with a lot of people who sell drugs. Not so much around fentanyl, because fentanyl and opioids, because people generally are either okay with having it or they want it. But working more so with finding xylazine in the supply and talking to people who sell and seeing if they're willing to change their supplies to have something that doesn't have xylazine in it, the veterinary tranquilizer that's been associated with a lot of wounds and abscesses and also sedation. And we've seen that a lot of the folks who engage with us, who are already like engaged with the harm reduction program, are willing to change their supply if they have the ability to do that. It obviously, runs the full range of possibilities of what might happen, but some people are, first of all, really invested in knowing what's in their drugs because they don't know they don't know what's in their drugs. And then once they find out what's in their drugs, then they're willing to do something about it to change what they can. Not always, but sometimes.
And what we found in recent years here is we've got a lot of street level pharmaceutical salesmen, and where crystal meth is still a big thing here. We have people that have bought presses, and they are pressing their own pills. And they have actually, I've seen some really good ones, and I've worked with, DEA task force, and we've made some arrests on some and confiscated some equipment, and they're getting high dollar and high tech when it comes to that. And they're the ones that are pressing these pills with an extreme amount of fentanyl in them, and we're causing the ODs. We also, as part of one of our programs, we have a harm reduction kit that does include, in fact, Narcan. And there's information as to how to use it and all that within the kit. We'll do training on it for them if they need it. And they're not necessarily for the street level guy, but for the guy whose mom has dementia, and she's had some surgery, and she's on some opioid and all that, and doesn't remember whether she's taking her medicine or not. That's a good backup for them to have for an opioid overdose. So we try to push hard on that. And I was trying to figure out the test differences in the equipment and where we might be able to go from here with it.
Yeah, thank you for sharing. Is there anyone else that had any other questions or, yeah, is it Shar?
Hello. So my name is Shar. I'm with South Dakota Urban Indian House in South Dakota and Sioux Falls. And so we're nowhere near states like New York or North Carolina. We have a lot of laws and policies in place that kind of limit what we can even do as far as harm reduction. So we have to be creative. So learning about what you guys are doing out there is really awesome to hear. My questions were like, as far as just like getting people to utilize that service, and like, how did you kind of build that level of trust with the community to get them to use the service?
Sure, I'll jump in real quick, and then if other folks want to add. We really leaned hard on existing community relationships. So like organizations that hire from the community and are part of the community, and like folks who use drugs also work there, and like the community is kind of enmeshed within the organization and outside the organization. That just made that pretty easy because it was the community buy-in was already there, the trust was already there. There wasn't this idea of like, oh, like the staff wouldn't bring in a cop to arrest me for bringing in my drugs, so this should is probably fine. I think for us it was more of really showing people that that we weren't going to take their drugs away, like use a lot of it, which for us we were able to use incentives, and that's kind of been a mixed bag in terms of uptake, because like people like incentives, but then when the incentives go away, then they also go away, so that's kind of like a complicated thing. But I would say if there's opportunities for demoing and showing how little sample is used, and then showing them that we give them the samples back, then that has been helpful for us.
Yeah, we do have fentanyl testing strips. So we have a unique location. So we're a clinic, but we were able to branch out and get a downtown building specific towards our street outreach initiatives, and then also a lot of our cultural groups and classes also take place here. And so we definitely have built quite a bit of trust with our unhoused relatives that we have, and people from the community. But yeah, and when we had the fentanyl testing strips out, I seen them, how fastly they were going. And so I was like, I wonder if they're really understanding the use of them. But our street outreach team did a good job of learning and kind of speaking and that information, but it did sound like they did know what the use of them were for. But that was kind of something too, is just that understanding, I think, is really important.
I'll also maybe add that I think it's important to give folks time to come around to it too, right? Like it's a really big shift for people to go from like, hey man, you can't have that out in the drop-in space, like I'm gonna ask you to leave, to like, yeah, no, bring it, bring it over and I'm gonna test you I'm gonna test it and tell you what's in it. And so I think just factoring in that like the ramp up can be slow and just being really consistent, reliable, making sure that you're in the place that you say you're going to be when you say you're going to be there. And then also kind of engaging kind of like key community members, folks who are like early adopters is a strange way to say it, but like early adopters of drug checking who are really into it and really excited about it. And a lot of times they're the ones going back to their community, collecting samples, bringing them back to the program on behalf of everybody, and kind of being the brokers of that trust and that relationship. And then those are also really great people to like bring in as technicians too, right down the line. Like if you find people who are really big advocates of drug checking are able to speak about it in a way that connects with people and connects with the community, those are really great people to have on your team.
I see Elise has a question.
Just a comment. I don't know which agencies are giving them to us, but we get fentanyl test strips provided to us either by the county or the state, and in California. And we also give and same with Narcan kits. And every new patient that comes into the clinic is trained in the Narcan use and the fentanyl test strip use and ways to use it multiple times. And so every new patient gets at least several fentanyl strips and 2 Narcan kits and information about using it with fentanyl. So I just wanted to tell you that. Oh, also I wanted to tell you on the internet, if you do a search for FTIR, there's a used machine available for $6,000, and they run in price. You can get them for $22,000 and up, and there are like 10 different manufacturers that make them.
Yeah, that's another thing to balance with the world of drug checking is there's a lot of things that are in the marketplace, but not a lot of them have been tested for the purposes of harm reduction. So, we're all kind of like learning as we go how these machines work, what machines work in the best settings, what machines have been, kind of tested for the purposes that we're using it in the community for. But that's really great that the clinic that you work with has test strips and Narcan available to folks.
I think we just have like a minute left if anybody has any final questions or comments. All right, well, thank you so much, Yarelix, Claire, and Taylor for being here today. This was great. And it was great to see how many people are here from all over the place. We really appreciate you joining us today. So thank you again, and we'll see you next time. Everyone have a good rest of your day.